Hi, this is Nicholas Crimes, and this video is to demonstrate the performance of commonly used oxygen delivery devices under a variety of conditions. The first device being demonstrated is the Liddell reusable silicone bag valve mask. A significant design feature of this device is the presence of a valve on the expiratory port. In this spontaneously breathing subject, this valve can be seen opening during expiration and closing during inspiration. Closure of the valve during inspiration prevents entrainment of room air, which allows the spontaneously breathing patient to generate a sufficient negative pressure within the mask to open the duckbill inspiratory valve. High concentration oxygen can then flow from the bag and reservoir to the patient without being diluted by ambient air. This enables this device to deliver inspired oxygen concentrations in excess of 95% to spontaneously breathing patients during normal tidal ventilation. During hyperventilation, however, if minute ventilation exceeds fresh gas flow, ambient air will begin to be entrained through valves at the base of the device, leading to a dramatic reduction in the inspired oxygen concentration. End-tidal oxygen will also inevitably fall, as can be seen starting to occur here. In the absence of a valve such as this, the expiratory port represents a low resistance pathway through which room air can be entrained during inspiration. This occurs when using the Mayo disposable bag valve mask, which lacks a valve on the expiratory port. This allows room air to be entrained through the port during spontaneous inspiration, which limits the ability of the subject to generate a negative pressure within the mask and restricts the opening of the duckbill valve, leading to a decrease in the fresh oxygen flow available to the patient, an increase in the proportion of room air inspired, and an overall fall in the inspired oxygen concentration. This decrease in the ratio of fresh oxygen to room air that's inspired means that devices without a valve on the expiratory port have a diminished ability to deliver high oxygen concentrations to spontaneously breathing subjects, their performance in this demonstration being similar to that of a Hudson mask. As with the Liddell bag, asking the patient to hyperventilate using the Mayo device leads to a further decrease in the inspired oxygen concentration. During positive pressure ventilation, increased pressure in the bag opens the duckbill inspiratory valve, while the fact that a negative pressure is no longer being generated within the mask means that entrainment of room air does not occur, even in the absence of a valve on the expiratory port. Thus, this design difference no longer has an impact on oxygen delivery, and during positive pressure ventilation, devices without an expiratory port valve are still able to deliver inspired oxygen concentrations above 95%. Supplementing the inspired oxygen flow to the Mayo bag valve mask using nasal prongs, connected to a second oxygen rotameter set to 15 litres per minute, raises the measured end-tidal oxygen at the end of a 3-minute period of spontaneous tidal ventilation to 85%. This produces equivalent levels of alveolar oxygenation to those seen with the Liddell bag valve mask. Addition of a valve to the expiratory port of the Mayo bag valve mask prevents entrainment of room air when a negative pressure is generated and restores its ability to deliver inspired oxygen concentrations in excess of 95% with spontaneous ventilation. Addition of a PEEP valve to the expiratory port has an identical effect, again allowing the device to deliver high oxygen concentrations to spontaneously breathing subjects. Another common resuscitation device, the Mapleson B circuit, is demonstrated next. The Mapleson B lacks the separate inspiratory and expiratory ports of the bag valve mask, and inspired gas is instead exhaled into the device, relying on an adequate fresh gas flow to flush it out via the pressure relief valve. The Mapleson B is able to deliver inspired oxygen concentrations greater than 95% during spontaneous ventilation. In contrast to the bag valve mask, the inspired oxygen concentration delivered by the Mapleson B is unaffected by hyperventilation, remaining at greater than 95%. Evidence of rebreathing is apparent on the end-tidal CO2 trace during hyperventilation, however. This is consistent with the expected performance of the Mapleson B and did not lead to hypercapnia in our subject. When using a standard Hudson mask during normal tidal ventilation, the flow rates with inspiration may be much higher than the 15 litres per minute of fresh oxygen flow being delivered by the oxygen tubing. This leads to entrainment of room air through the ventilation ports and around the edges of the mask, which dilutes the inspired oxygen concentration. Demonstration of the standard Mayo Hudson style mask following a 3-minute period of pre-oxygenation produces an end-tidal oxygen measurement of 44%. This is roughly equivalent to the performance seen during spontaneous ventilation when bag valve mask devices which lack an expiratory port are used. Supplementation of the oxygen flow to the standard Hudson mask using nasal prongs attached to a second oxygen source at 15 litres per minute raises the end-tidal oxygen after a 3-minute period to 69%. The standard Mayo non-rebreather mask has a valve between the mask and the reservoir bag. During expiration, this valve closes, preventing the expired gas from entering the bag whilst allowing fresh oxygen flow, which would otherwise be wasted, to accumulate in the reservoir bag. During inspiration, this valve opens and the accumulated oxygen in the reservoir bag supplements that being delivered by the fresh oxygen flow. Thus, a greater proportion of the inspiratory flow is met by the 100% oxygen sourced from the fresh oxygen flow and the reservoir bag. Following a 3-minute period of breathing with this mask, an end-tidal oxygen of 59% is achieved. When oxygen flow to the standard non-rebreather mask is supplemented using nasal prongs attached to a second oxygen source at 15 litres per minute, this further raises the end-tidal oxygen to 83%. This end-tidal value is comparable to that achieved using devices which deliver an inspired oxygen concentration approaching 100%. The Mayo non-rebreather mask number 2012 features an additional valve on one of the ventilation ports to limit entrainment of room air during inspiration. After a 3-minute period of breathing, this mask produces end-tidal oxygen concentrations only slightly higher than that of a standard non-rebreather mask. The Mayo non-rebreather mask model number 2014 has bilateral valves on the ventilation ports in addition to the valve between the mask and the reservoir bag. During inspiration, these valves are intended to limit entrainment of room air through the ventilation ports. Although visible movement of the valves is not evident during normal tidal respiration, this slightly further raises the end-tidal oxygen achieved after 3 minutes of breathing to 71%. As minute ventilation is further increased, however, the closure of the ventilation port valves in combination with higher inspiratory flow rates leads to a negative pressure developing inside the mask during inspiration. Unlike the bag valve mask devices, the non-rebreather mask does not have valves which allow entrainment of room air when the inspiratory flow exceeds the capacity of the fresh oxygen supply and the reservoir bag to deliver high concentration oxygen. Thus, once inspiratory flow outstrips the oxygen supply, without the ventilation ports to make up the excess gas flow, the device collapses, causing acute transient airway obstruction and preventing further inspiration. To determine whether this phenomenon was being contributed to by the supine posture of our subject, we repeated the demonstration with the subject in the upright position and observed the same result. This was an unexpected occurrence, and whilst it required vigorous hyperventilation to produce sufficient inspiratory flow to cause this phenomenon, it represents a potential concern which could limit oxygen delivery via this device to severely dyspneic patients. In summary, when used in spontaneously breathing patients, bag valve mask devices without an expiratory port valve only provide an inspired oxygen concentration similar to that achievable with a standard Hudson mask. These devices are not suitable for purposes such as pre-oxygenation prior to airway management or resuscitation of spontaneously breathing hypoxic patients in whom a Hudson mask has been inadequate. In spontaneously breathing patients, high end-tidal oxygen concentrations consistent with provision of an inspired oxygen concentration approaching 100% can be achieved by using bag valve mask devices with an expiratory valve or a PEEP valve, or by using a Mapleson B circuit. Equivalent levels of oxygen delivery can also be achieved using bag valve mask devices which lack an expiratory port valve and with non-rebreathing masks, provided that oxygen supplementation via nasal prongs is also undertaken. The impact of an expiratory port valve on the performance of a bag valve mask device is only evident during spontaneous ventilation. With positive pressure ventilation, all bag valve mask devices provide an inspired oxygen concentration of greater than 95%, irrespective of the presence of an expiratory port valve. In all bag valve mask devices, irrespective of the presence of an expiratory port valve or the mode of ventilation, the inspired oxygen concentration will ultimately fall with sufficient hyperventilation. Finally, non-rebreather masks with bilateral valves on the ventilation ports may cause obstruction and limit inspiration if exposed to conditions of sufficient hyperventilation in severely dyspneic patients.